name is Randy Bell. I am a recently retired active duty Navy military neurosurgeon, now as a civilian at the Avera McKennan Hospital and University Health Center in Sioux Falls, South Dakota. Wanted to talk to you today about the management of penetrating brain injury. Start with an illustrative case to help frame the conversation. This is a 16-year-old male who presented with a high-velocity missile injury to the left parietal lobe. The injury occurred from a 9mm handgun fired at close range. Again, you can see the left parietal entry. There is a left orbital frontal exit site. CT scans reveal significant disruption to the left hemisphere with brain protruding from the exit site. You can see subarachnoid and intraparenchymal hemorrhage present, likely indicative of cerebrovascular injury, and there is significant skull disruption and some retained metallic fragments. The patient's physical examination at presentation was a 6T. So overall, penetrating traumatic brain injury, or PTBI, is an unfortunate and common catastrophic primary wounding mechanism that is encountered in civilian and military settings. It is characterized by foreign material of some kind breaching, piercing, or infiltrating the skull and brain. Important PTBI sub-mechanisms include high-velocity missile injuries like those that occur with bullets, low-velocity fragment injuries like those that can occur from improvised explosive devices, or low-velocity sharp objects like knives or nails penetrating through the skull and brain. Pathophysiologically, low-velocity PTBI causes irreversible local damage to the brain, while high-velocity PTBI involves additional diffuse injury from cavitation or secondary cavity, as well as that subsequent secondary brain injury that can occur in really all brain injury. Overall, we know that PTBI has a high mortality in civilian and military settings, though it is possibly lower in military settings. We also know that meaningful study in this area is compromised by the low survivability, and as such, guidelines which were initially published in 2001 for the management of penetrating brain injury have not been updated since. So with this in mind, what do we really know about penetrating brain injury? Well, we know that it is highly lethal, that time to decision making is very, very short in most circumstances, and that the prognosis and survivability is often low. How then can we approach this condition? Well, the following will go over a few selected studies that I find useful when thinking about this process. The last part of this talk will actually preview the upcoming and currently in process revised guidelines for the management of penetrating brain injury and the algorithm that will accompany these guidelines. So concerning prognosis or survivability, these I view as really two different things. A patient may survive with a very poor prognosis, so that's important to keep in mind. This SPIN score was devised out of the University of Maryland and published in 2016. This score helps to utilize presenting patient characteristics in an effort to help predict survivability. You can see that heavy weight is given to the motor GCS score, the pupillary score, the presenting injury severity score, which is a marker of associated injuries to other parts of the body, and the patient's presenting INR. In this case, the higher the SPIN score, the higher the probability of survival. So you've determined whether or not the patient is possibly going to survive. The next question you want to ask is, does this patient require surgery and when? For major injuries, sometimes that can be immediate. This paper published from the United States military in 2018 looked at the associations between survival and timing to surgery and penetrating brain injury. This was a very large population of military penetrating brain injury. What this determined was that the probability of death increased significantly if a patient did not receive required surgery within approximately 5.3 hours of their injury. So you have determined the patient may survive, and you've determined that the patient requires surgery, and you act on that. The next question is, how will the patient do long term? Or, phrased another way, what am I going to tell the patient's family? This is another study of penetrating brain injury out of the United States military, which looked at long-term outcome or Glasgow outcome scores and how they were associated with presenting initial GCS score. The population of penetrating brain injury patients was stratified into two populations, those with a presenting GCS of 6 to 15 and those that presented with GCS of 3 to 5. Overall, all of those who presented with this GCS of 6 to 15 survived and improved with time, as you can see in the graph. And not surprisingly, all those who presented with a GCS of 3 to 5 did worse from a Glasgow outcome scale at all time points. That being said, there were some surprises in this study. The overall mortality was approximately 21%, which is significantly lower than that seen in civilian populations. And not surprisingly, 11 of the 31 patients who presented with a GCS of 3 to 5 did not survive. When those who did not survive were removed from the analysis, the remaining patients who presented with a GCS of 3 to 5 had very good GOS scores at all subsequent time points out to 2 years, with good functional survival. This does raise the question of the accuracy of the initial assigned GCS score, but is encouraging when it comes to when you decide to intervene. So with this in mind, how can we think about this process in a way that actually will benefit our patients and also not result in perhaps nihilism? We know that we need revised guidelines for the management of this very complex process, and these are currently underway. There is an assembled large group of subject matter experts from around the world that is currently reviewing literature and creating the guideline as well as algorithm that will accompany the guidelines. This algorithm will create a decision process that considers the injury severity and mechanism, patient presentation characteristics, and then how to logically proceed and flow through the healthcare environment based on the patient and how they present. I will say this now and also conclude with this. The most important thing to take away from an evaluation of this patient, and really most patients, is that before you decide a patient is not survivable, it is critical that as the treating neurosurgeon or your subordinate, you need to evaluate the patient. And if you decide that something needs to be done, you need to do so in a timely manner. Do not wait. So starting from the point of injury, which in most cases is pre-hospital, the important take-home messages from this portion of the slide and this view of the preliminary algorithm is what you already know. Communication is absolutely critical. So the paramedic and or scene medical provider will often communicate with the accepting trauma facility. In the military, we call this a 9-line. That being said, important considerations in the field include hemorrhage control, possible placement of cervical collar, and evaluation of other injuries. If the patient requires rapid transport, or in this case flying, if a rotary wing or a fixed wing is needed, important to, at least in the fixed wing asset, have the patient's head towards the front of the plane. This will ensure that the patient's head is above the heart on takeoff. Once the patient arrives to the emergency room, the advanced trauma life support principles take over with a primary and secondary survey. The important issues associated with penetrating brain injury are the neurologic examination, CT scan of the head, and I would argue an immediate CTA as well, labs, and then an associated injury severity score. The first decision point, again, is survivability. In this case, we refer to that as salvageability. If the patient is deemed survivable or salvageable, that patient may then need to proceed to the second decision process, which is the need for surgery. If not survivable, the patient may proceed to the intensive care unit where organ donation services may be consulted, palliative care, and perhaps the initiation of catastrophic brain injury protocols that will help facilitate preservation of organs until donation can occur. Again, the second decision process is the determination of the extent of injury and need for surgery. This algorithm will propose likely two major areas, those that have minor penetrating brain injury and those that have major penetrating brain injury. In this case, the minor injury pathway is defined by a superficial penetrating injury or a superficial gunshot wound with a good presenting GCS, no suspected vascular injury, no aerated sinus injuries. These patients may present awake and talking to you. Many will not require surgery, perhaps bedside local debridement and closure. Others may require more extensive debridement in the operating room, but in all cases, they will proceed potentially to the intensive care unit for observation afterwards, where little additional critical care may be necessary. The major injury pathway is that which would be defined as a patient who presents with significant penetrating brain injury with multiple brain lobes injured, possibly midline shift or mass lesions present, patients who present with protruding foreign bodies like knives or pencils or chopsticks from the head, traumatic vascular injury, highly suspected, aerated sinus or skull base injury. These would qualify as a major injury. Some of these patients may not require immediate surgery, they can proceed to the intensive care unit. I would argue this may be the rare circumstance in a patient who you deem survivable. If you do, however, think they need to go to the operating room, this is where the immediate CTA becomes very important. Though not a long-term solution to the diagnosis of cerebrovascular injury from penetrating brain injury, in the short term it can give a very good picture of early traumatic aneurysm. In the setting of large skull-base deep traumatic aneurysms, it may be necessary to go, if the patient can tolerate it from an ICP perspective, to diagnostic cerebral angiogram and potential coil occlusion of this in the operating room. Once the skull is off, it is very difficult, as you know, to control aggressive deep arterial bleeding in the setting of significant brain tissue disruption and in-driven bone and other metallic fragments. Once completed and you do arrive at the operating room, again, the extent of injury determination is critical. We do advocate for early cranial decompression, early repair of skull base or sinus injury to help prevent the risk of cerebrospinal fluid leak and delayed infection, early CSF diversion, fragment removal if superficial and easily accessible, and then for the circumstances with protruding, penetrating foreign bodies, removal of those foreign bodies in a controlled fashion. And again, referencing back to the diagnostic cerebral angiogram, that protruding, penetrating foreign body like a knife would be a circumstance where a diagnostic cerebral angiogram prior to going to the operating room would be critical to determine the extent of vascular injury as you pull out that object. Once the operative management is complete, the next decision node is ongoing survivability. This occurs in the intensive care unit, where the management is largely dictated at this point by the recommendations provided in the 4th edition of the Traumatic Brain Injury Guidelines created by the Brain Trauma Foundation. Briefly, the special considerations in the setting of penetrating brain injury include the need for ongoing CSF diversion from ventriculostomy, which can also help with ICP monitoring, again, to help reduce the risk of delayed cerebrospinal fluid leak, which is associated with infection. Considerations for the timing and initiation of anticonvulsant therapy, antibiotic therapy, which will likely be necessary in most patients, and then antithrombotic medications for DVT and PE chemoprophylaxis, the timing and initiation of these. The additional considerations include the polytrauma patient with penetrating brain injury and the additional consultative services necessary to manage that, timing of follow-up imaging, including a CT scan of the head, and then, if not already completed, the performance of a diagnostic cerebral angiogram. I think the CTA, again, as an initial screening is very appropriate, given it can be done in a rapid fashion. However, because of often retained metallic foreign bodies, which can obscure the evaluation of cerebrovasculature secondary to beam hardening artifact, as well as the sensitivity of cerebral angiogram, it is critical in almost every case of penetrating brain injury with a major injury classification for a delayed cerebral angiogram to rule out evolving traumatic aneurysm and or the presence of traumatic arteriovenous fistula. At some point, the patient may not progress in a positive way and could initially be considered survivable and then become non-survivable. Organ donation services and end-of-life care could be considered in the ICU setting as appropriate. And then for those that do progress out of the intensive care unit, strong consideration for multidisciplinary team to help manage the eventual craniofacial reconstruction that may be necessary. And in this case, that would include plastic surgery, potentially oral maxillofacial surgery or ear, nose, and throat surgery specialists, and perhaps even ophthalmology. So the initial case, again, this 16-year-old male presented with a high-velocity missile injury to the left parietal region that traversed the entire dominant hemisphere with a left ortofrontal exit site. The patient was deemed survivable, and the decision was made to proceed for immediate operative decompression. The most important initial management decision that can be made is the early resuscitation. Based on this injury, it can be assumed that blood loss will be significant in the operating room, and resuscitation should start immediately. In this case, a 1-to-1-to-1 packed red blood cells, FFP, and platelet infusion is appropriate. This patient got 4 units of each and required an additional 6 units of the same proportions in the operating room, secondary to over a 1,000 cc blood loss. The trajectory, again, was through the sylvian fissure. There was significant vascular injury. You can see the disruption of the tissue there, the skull in multiple fragments removed individually. The dura also then opened with brisk arterial bleeding from multiple different sites. Most convenient in this case to control with the application of aneurysm clips when the injury was isolated. Occasionally, bipolar cautery was enough. Following this, you can see the postoperative CT scan shows evolution of the traumatic intraparenchymal hemorrhage as well as the subarachnoid hemorrhage. You can see the aneurysm clips that were necessary, and although not previously mentioned, the left frontal sinus was disrupted, it was exenterated, and vascularized pericranium, which was harvested during the rapid opening, was utilized to help to reconstruct the sinus initially. The patient then proceeded to the intensive care unit, where standard intracranial pressure management as outlined in the traumatic brain injury guidelines was initiated. Because the initial CT and CTA did not show significant vascular injury, a diagnostic cerebral angiogram was then performed at approximately 1 week after injury, and you can see there is a 4 millimeter approximate traumatic aneurysm of one of the distal M3/M4 vessels. This would have been difficult to see on a CTA. This is a terminal vessel. The underlying brain already is significantly injured from the trajectory of the bullet, and this vessel is therefore appropriate for apparent artery occlusion, which occurred with N-butyl cyanoacrylate. The patient eventually made a remarkable recovery. He was able to speak and walk. He was eventually reconstructed. He had some disability, but was eventually able to graduate from high school 2 years after his injury. So, in short summary of the surgical pitfalls, I think it is very important to repair CSF leak early, skull base injury early, aerated sinus injury early. I think a CTA is definitely acceptable acutely. I would not recommend relying on this as the sole mechanism to rule out traumatic cerebrovascular injury. Again, a catheter angiogram will likely be needed in most cases. In the setting of penetrating brain injury that might be considered major, I think it's important not to wait for midline shift to decompress or for the patient to decompensate to intervene surgically. There are injuries that impart significant energy to the head. It is predictable in the setting of most penetrating brain injury. If the patient is survivable and you think they will need surgery, I highly recommend doing so early. Also, do not create a small decompression if the intent is to decompress. That does not help the patient. Concerning salvageability or survivability, recommend that you rely on your examination or the examination of one of your neurosurgical subordinates before you determine the patient is or is not survivable. Oftentimes, patients will arrive in the emergency room having received sedation in the field for intubation. The initial GCS score from non-neurological or neurosurgical providers may not necessarily account for the variability in medications and other things. So before a decision is made, please rely on your examination. So in conclusion, penetrating brain injury is a lethal wounding mechanism. Many cases are survivable and salvageable. There are ways to determine that. I think in the setting of a complex injury where time is critical, it is important to develop a methodical approach. And this approach should involve decisive and early action if it's considered necessary. And with this in mind and recognizing that the prior guidelines are at this point outdated and did not include a treatment algorithm, the management of penetrating brain injury and the guidelines associated with these are currently in production, and a grant from and in accordance with the Brain Trauma Foundation. The guidelines and recommendations will also include a treatment algorithm that will help in this process. Thank you very much.